We welcome everyone to day 3 of our conference, and we thank you all for staying with us for the 3 days, and we are very delighted that we have such a wonderful and engaged audience. To begin our day today, I invite our very own Dr. Sanjeev Jain, our academic director of BALM and professor emeritus of NIMHANS, to please make some opening remarks. Thank you.
Good morning, everyone. I'm trying to summarize the events of the last 2 days, which have been exciting, exhilarating, and exhausting, I guess. So we started out yesterday morning on this interesting conference on home and health, counting numbers as usual. We counted that there are probably 1 billion homeless people in the world, and about minuscule 1,000 of them live in India, which is quite unlikely because India is 40% of the world's population. So it's quite unlikely that we have only 1 millionth of the homeless. And then Dr. Kishore took us through this entire journey of the 30 years of the existence of Banyan, the challenges that they faced from converting a hospital-based care models, handling issues of poverty, the invisible narratives of the patients themselves, and extremely poor physical health that they often encountered in the people that they served. They've looked after more than 5,000 people in 30 years, and 60%, about 2/3 of them have been, inverted commas, reintegrated into their families and societies, leaving behind about 1/3. And as we all know from our bank accounts, that if you have a 33% interest, your account doubles in about 3 years. So the number of mentally ill in institutions will keep doubling almost every 3 to 4 years. And therefore, home again becomes a necessity so that the long-stay patients or the long-term care of these individuals can be looked after much more efficiently. And how it's time to change the narrative from not the 19th century and the 18th century and the mid-20th century dialogues of institution versus community, or whether they are equal, but actually work together to create healing spaces, both physical and metaphorical, to help recovery. So long-term care, as you pointed out, will always be necessary. And the social determinants of this, of inequality, disparities, and the research to find the appropriate local narratives or local methods is absolutely necessary so that one can co-produce an inclusive space where these cares can be delivered. Sahu from the administrative services emphasized that there's a need for robust healthcare to underpin all these services. You need collaborative efforts, and you need, and for example, in Chennai, in Tamil Nadu, they have more than almost 700 mental health NGOs or services registered with them. Dr. Henderson pointed out how loneliness and food insecurity, the interventions range from biomedical, of making sure that their physical condition was there, to handling loneliness, to handling the food insecurity, including growing plants on the hospital roof, and adding an 82-bed facility. And that segued into the findings that very often the police and the legal system had become the primary providers of healthcare in their setting. The next session was, as Dr. Ram summed it up, there was an interrelatedness of many of these factors which led to homelessness, mental illness, deprivation, and how this inhibited from human beings from achieving both their aspirational and capabilities in keeping them in sync. D'Angelo gave us a very first-hand account of the ROAD program, which actually looked at the nuts and bolts of life on the street and how to help them in the most efficient way within the facilities that they have, and how they incorporate various professionals from the police and the psychologists and the psychiatrists to do this. We heard a lot of effort from the HOPE program, collaboration between Ethiopia, Kenya, and Ghana, the first phase of the study, which you can all see there, as to how there will be a gradual amplification of community-based networks so that there can be a qualitative change in the care of the mentally ill. This was followed by another seminar, which was where Professor Messina gave a very illuminating account of the historical antecedents and the and the outcomes of the Trieste program, which has served as, in some way, as a lodestar for many such programs all over the world. It's provided a conceptual framework which is different, followed by many of us institutionalized psychiatrists, myself, Dr. Desai from EBHAS, Padmavati from SCARF, and Tasneem from the NGOs who support many of these efforts. The discussions were based on choice, agency, the rights to health, the rights to dignity, and the right to freedom. And how do you negotiate these different rights, which may each get compromised at different points in the care journey? And how do you ensure that there's a thread of dignity and care and continuity, despite all these varying conditions that the person may have? It was followed by a discussion on post-discharge planning, which was led by Professor Shashidhar, a doyen in the field of community psychiatry, Matthew Verghese, who works on long-stay patients also, Tanya from the self-help groups. And this was also pointed out that, that engaging care over a lifespan and over time, therefore becomes essential quality to have. That was followed by a very nice presentation on mindfulness, on mind lines in mental health care to see. And to my mind, that looked almost like a biological network. You know, all the networks that you see them around, you could change the names, and the cell biology network of schizophrenia would look much the same. So you could think of schizophrenia as a metaphorical network from molecules to societies. The chairperson gave us interesting details about his work with other institutions like jails and the high need for mental health care in jails and other incarcerated populations. The second day was introduced by Deborah Paget on the Home First program, who gave an account of all the efforts she had made and how that effort has been now replicated in many, many sites across the world and the successes it has had in many situations. This was followed by the team Banyan giving us an account of all the actual performance from their recent submitted paper, the profiles of the patients, the kinds of problems they have had, the lived experience of some of the users, and highlighted in great detail the kind of ups and downs and the nitty-gritty issues about about helping with care of these persons. Professor Mazzina and Pina again led us through the qualitative and real aspects of transformative care with details, and I was very envious that for your population of 1 lakh, about 60,000 to 100,000 people, you had 23 psychiatrists and n number of psychologists for that. 250 for us. So that's a level of staffing which appears almost light years away from what we have now, but we'll get there. Then was followed by a very engaged debate and summarized by Mr. Glick, who gave the NGO, the financial backing and the NGO sector as to how we can raise funds for this. Then we had a very interesting afternoon sessions with Vijayanand telling us about the palliative care movement and finding out and telling us that they have almost 160,000 registered users, which is, I think, more than the number of registered users on sustained follow-up for mental health, at least in India. We don't have a registry of that kind or even numbers of that kind. And how they could motivate the community and community networks to form this backbone of services, which has really changed the way cancer is perceived, managed, and treated in society. And that would form a very useful model, at least for handling certain kinds of mental health issues, especially the chronic ones. After that, we had a large number of first-person accounts from Orissa, from Madhya Pradesh, from Maharashtra, from Tamil Nadu, from Karnataka, parents groups, patients groups, community health organizations, and users. So this was, this in a way also showed from the ground up the worm's eye view as to what a change this kind of community participation can make in the outcomes of mental illness. The concluding session started with Dr. Sujata Rao, who emphasized that scaling up of government support was very, very essential. If all these programs were to influence the largest amount of population, these could be seen as pilot programs, but scaling up with government help was absolutely necessary. Professor Vijayanand again talked about a good heart and a good mind. For those who know Hindi, that means nek irada or nek niyat, with both of which concepts are a bit difficult to find in India, both the niyat and the irada. So that niyat and irada have to be in sync. Dr. Sutoya from the WHO reaffirmed the commitment of the WHO, keeping in mind the outcomes and the trajectories of the patients, that mental health is not a static need. The patient's conditions vary, the needs vary, and one has to evolve a system which responds to these kinds of variations. Dr. Ganesan from Sri Lanka reminded us that homelessness is actually a universal problem, and global and local cannot really be separated. There's a lot to be learned in the global world, north, south, east, west, wherever, from the local issues that we experience as care providers or care users, and how society itself is being affected by larger political forces. The migration of young people from villages leaves a lot of people living in solitude and loneliness with no care support mechanisms. And these processes of solitude, migration, and diminution of so-called social capital from factors which are beyond the individual are also need to be kept in mind. Mr. Glick again pointed out that some kind of evaluation was constantly necessary. It would be useful if these methods, if the rules for the assessment were defined by the organization themselves and constantly assessed. At the end of the 2 days, we were exhausted but invigorated. I think we ended up well after 6, so it was quite a long 48 hours. But what was important was the repeated assertion that the idea behind it is that the last left behind should be looked after. This goes back to something that John Ruskin had written, the first book, one of his books, Unto the Last, which was the founding principle of Mahatma Gandhi's life. So this idea that the last behind should be looked after the best, or to the best of our abilities, is a prevailing notion of political progress over the last 200 years, right from Ruskin to Gandhi to now, which seems to resonate with all of us. So I think we should not leave that thought behind. The other thought that came was, many years ago, there was a conference on disability in Bangalore, and one of the speakers got up and he addressed the audience as temporarily abled, because the idea was that 30% of all people would have some disability for some time in their lives. I wish I could say that to the audience of temporary sane. People would not like that. But temporary sane and temporary insanity, or the fact that one should view these things in that same spectrum, that none of us is actually immune from insanity at any point of time. I work most of my life as a geneticist, and whatever we have found, we know that the genetics of schizophrenia is no different from the genetics of normality, whatever we define normality as. So there's nobody who's schizophrenia free in their biology. There's nobody who's not completely free of whatever, recovery in either case. At the end of the day, Ms. Sujata Rao made the very emphatic point of building institutions of care, as her experience with NACO showed. And whether institutions are, again, brick and mortar, or ideology, or a particular attitude, or a particular emotional resonance, the institutions should not be seen as independent of society at large. We need institutions. We apparently need democracy. We apparently need a government. An institution is no more or no less than the governments and societies that they create. So on that note by Sujata Rao, of reaffirming the need to build institutions of care, as she had successfully demonstrated with the NACO and the PHFI, we ended the day, and now we are here again to start the next and the final day's deliberations. Thank you very much for your attention.